Hello, I'd like to welcome you to Dental Office Medical Emergencies. We're going to talk about the most common medical emergencies that you could see in a dental office. We're going to be studying them ranked on probably the ones that you will see most often, and then we'll end the course with some of the rare ones you'll see but that can occur in a dental office. The presentation is for every dental team member, and we want you to have your team trained so that they can help you in case there is an emergency in the office, that they will help recognize it and help take care of the patient. So this could occur to fellow employees. It could occur in your family. It could be during a family event or a holiday. And even you as a human being can develop medical urgencies that could progress to medical urgencies like chest pain, asthma, choking, these sorts of things. Not every emergency that occurs at the dental office, obviously. It can occur when you're taking your pet to the vet. It can occur when you're going to a shopping center or to a ball game or a race, football game, baseball, whichever. It can occur in any of those places, and you will be able to respond comfortably when you take the course and we go through things with you, and then you practice what we're going to be talking about. So with proper preparation, training, and again, those practice drills, your office can really help the patients and not go into a total meltdown mode, because emergencies are more urgent, and that's the most common type of emergency you're going to see as a medical emergency in your dental office, as opposed to an emergency. So there's more urgencies and not emergencies. They are rare to have the emergencies. I refer you to your State Dental Practice Act. You all, as dentists, should be familiar with your State Dental Practice Act. In those, they talk about your emergency preparedness, what they expect for you to be able to do for your patients while your patients are seeing you in their office. So I would use them as the guide. I used the Missouri Dental Board rules and such so that I would know how to act and how to write up our lecture even today. So that's going to be your most up-to-date source for your training for you and for your office. Every one of the emergencies is based on the CABDs of basic life support, or BLS, also known in other names and other places as CPR. With BLS, remember that we're performing the CABDs, as we just said: circulation, airway, breathing, and then defibrillation, which you want early defibrillation. And again, practice frequent drills. This is really good to be able to then go ahead and document and keep in a folder in your office in case you get a visit from the dental board, or if they require to know if you're doing any training at all with your personnel. So write down and keep track of, on a piece of paper, your names of your personnel, who's performing the training, the topics that you're discussing, and we're going to be providing you dental office medical emergencies that has algorithms that are what I use when I treat a patient. I'm not saying they're the be-all, end-all with the way that I wrote the algorithms, but you'll have that, and you can put a copy of that in your emergency cart or with your emergency drugs and your emergency kit. So you'll talk about what topics, again, you're discussing, and that will help with the algorithms that you're going to be getting, and the date of the training and how much time you spent training those. And I would do those at least quarterly. So fortunately, the emergency that you're going to see in the dental office, it is rare and it's not life-threatening usually, is going to be syncope, which is also called hypotension or fainting. But there's other anesthesia-related medical emergencies that can and do occur, but as again we said, it's really rare. So as professionals, our public, our patients trust in us to provide the absolute best of care. It's just not a matter of sitting down with a high speed or with an extraction forceps or whatever, but the other things that we do to totally take care of our patients. And it's a good word of mouth thing to be able to attract new patients and knowing how professional you are and the trust that they place in you. So be your absolute best. So the anesthesia medical emergencies that we're going to discuss are, and they can occur really any time. They can occur just in the waiting room or as we're discharging the patient, whatever. But let's review those. And the learning objectives for the course are we're going to talk about the prevalence of several major anesthesia medical emergencies possible in the dental office. It's the importance of and familiarity with these common medical emergencies. And as we said, periodic drilling and training and review for you and your staff. Do whatever your state dental board asks you to do. We're going to look at 13 of the most common dental office emergencies, medical emergencies. We're going to review some suggested treatments. They're the things that I learned when I was in anesthesia school and what I practice to this day when I've got patients that undergo these emergencies in the operating room. We're going to talk about briefly the pharmacology of the treatment of these various anesthesia medical emergencies, and we'll talk about suggested dosages for these agents. The disclaimer tells you that, again, we try to be able to tell you what it is, the way that we do things, but we can't guarantee an outcome. There's other sources, there's other textbooks and other lectures that you can take, and that you should mix these things together so that you are proficient in being able to take care of your patients, especially if they're undergoing a medical emergency. So before you start any dental hygiene case, you've got to make sure before you even start that the patient is ready. The operatory is ready. The monitors are working and ready. Oxygen is available and ready. Suction and suction tips are ready. We've got our medications on hand and nearby, along with syringes and needles. The emergency cart is readily available and in sight, and then communication links are possible. So make sure that you're absolutely ultra familiar with your drug kit, your emergency equipment, and your supplies, and that you know how to use these things. Don't just leave them in the package. You've got to review on how you're going to put things together, how they work, how they insert, how to use them on the patient. You've got to make sure that the equipment and the supplies are in perfect working order. If they require batteries, then make sure that you've got fresh batteries nearby. Everything is clean. Make sure your drugs are not expired. I can tell you that if the board is coming to do an inspection for you, they will look at random bottles of your drugs and see if they're expired or not, and make sure that they're well stocked with what you need for each of the emergencies that we talk about. And there'll be other emergencies too that we may not have covered, but we're covering the 13 most common that I have seen in dental offices and I've experienced, as I said, in the operating room. So make sure you know what everything is in that kit. You're ultra familiar with it. During the emergency is not the time to be learning about these things. You've got to be able to pull them out, know what to pull out, know what to use, and get on it, because time is against you when you're taking care of a patient with an urgency or an emergency. And again, practice those regular drills. And it's good to have a checklist. It's an excellent idea for patient care. Pilots use it. In anesthesia, we're using it. We go through a checklist to make sure that we've got everything ready and in place so that we don't forget anything. This is an example of a checklist for office-based procedural sedation and anesthesia. So just gives you an idea of what you have to have and to make sure that it is ready for every patient, especially as you're about to use or apply sedation to them. All right, so everything and everyone are ready. And here is another type of checklist that your front office can use. It's called the IV anesthesia checklist. And you can see that it's got 8 similar or they're identical checklists. And you can cut those up and take a picture of them or put them with the patient's digital chart to make sure that you have got everything in order so that the patient is ready to rock before you start their dental procedure and or their dental sedation. So in order to have the operatory ready, we must know that the CDC, the Centers for Disease Control, and it might seem like it's obvious, but we only use 1 needle, 1 syringe, and we only use it 1 time on 1 patient. There have been instances where the person has, quote, tried to save money by reusing needles or washing the syringes or whatever, and they are so inexpensive now. There was a group back in the 90s, and I know that was a long while ago, that was reusing syringes, and they were using propofol bottles between patients, and there were over 30 patients that were contaminated with hepatitis C. Every one of those healthcare workers, the dentist, the physician, all the way down to the dental assistants, lost their licenses to practice if they had one. There were heavy monetary fines, and there was even jail time involved with something giving a healthy patient hepatitis C. So if you look at the picture, if you see that the gloved hand has got the plunger out, as soon as you push that into the barrel of the syringe, you can see that you've pushed something contaminated into that syringe. So just don't do that. So let's look at some dangerous misconceptions. And I'm pretty sure you're going to know what these misconceptions are. So let's look at some of these myths. So changing the needle makes a syringe safe for reuse. Well, there's that word reuse. And once the needle has even touched the tip of the IV hub or touched the skin of the patient or however you're giving the med, once it's touched, the whole syringe is shot unless you go ahead and change the needle and use it on that same patient. Do not use it on another patient. The next one down is the syringe can be reused when injecting through IV tubing. There's that reuse again, and you know that is absolutely not saving any money and really causing your patient harm. Is this the way that you would want somebody to take care of you? So if you don't see blood in the IV or the syringe, it's okay for reuse. And you can see there's that word reuse again. That is just an absolute no-no. And it's okay to use single-dose medications. You know, there's single and multiple dose medications on more than one patient, and that is an absolute no-no also. So part of the operatory being ready is to make sure that all of your available medications are, again, not expired, just as we talked about earlier. So let's talk about expiration. We already talked about these vials. So as you can see, etomidate, the drug that we use to get the patient off to sleep, it doesn't cause heart rate or blood pressure changes as we're getting them off to sleep for a general anesthetic. That there is a single dose vial. Then there's the atropine single dose vial. Then there is the dexamethasone or Decadron multi-dose vial and the multiple dose 2% lidocaine plastic vial or bottle, whichever. And these multiple dose vials have preservative in them where the single dose do not. So there's no preservative again found. So if you look at and you should know when something expires. If it's an unopened single dose vial, it expires MAR 2034. So that would be March of 2034. And you're asking, well, what day is that going to be? And it's always the last day of that month. So that is what the manufacturer says as far as it being fresh and up to date. So if it doesn't have a number, if that same single dose vial said MAR 92034, then it would expire March 9th of 2034. So if you have a multi-dose vial and you pop the cap on it and open it up, it expires that day. No matter what the expiration says on the bottle, you've popped the top. Of course, you're going to wipe the top of the bottle before you draw the meds out with an alcohol wipe. But once it's opened, it's done that day. They say that you should draw up meds, they being the Joint Commission for Healthcare Offices and Hospitals. If you've got a patient in the operatory, you don't draw the next patient's meds up in the operatory. If there's no one in the operatory, then you can go ahead and draw those meds up there. But you just want to find a clean place where there's no patient treatment going on. So again, multiple dose vials have preservative. So we again want to draw those up in a clean environment. Once you've popped the top, you want to go ahead and wipe the top with an alcohol wipe before you stick the needle in through the gasket that's at the top of the bottle. So no trash, no blood, no unclean environment when you're drawing up any of the meds, be they a single dose or multiple dose. This is a 2% lidocaine, and it says it expires MAR 2034, and it's unopened. So we can see from what we learned with the single dose vials that MAR 2034 is again going to be the end of the month because it's unopened. It's going to be March 31st of 2034 or 2034. If it's opened, you've got 28 days from where we are today, wherever the day that you opened it. So if it's the 1st of September, you've got until the 1st of October, which is 28 days, to use it. So I would take a Sharpie, draw an up arrow, and say that you opened it. Say again, it was September 1st you opened it. You can draw an up arrow and write 9/1, showing when you opened it, and you've got 28 days to use it. And I would then initial it that you are the person that popped the vial open. Before you draw the meds out, if you see such things as any blood, particles, goldfish, any trash that's floating in the vial, toss it. It's just not worth getting the patient sick. You have to think about, would I want this for myself besides my patient? Would I want somebody to be that uncaring and not taking care to make sure that you're going to be absolutely safe for that patient? And as a standard of care, especially with narcotics and such, the anesthesia provider draws up their own meds. I know that some states allow this, but you should never be that busy that you don't draw up your own meds, label them properly, and keep them, especially if they're scheduled drugs, narcotics and such, like we see fentanyl and we see Versed or midazolam there. We don't want anybody to divert those because they can be a penalty for not only you, but they can harm your worker that's putting, say, sterile water or sterile saline into the syringe and taking, say, 100 micrograms of fentanyl with them, because you just can't tell the difference. So draw up your own meds. That is a standard of care. Again, look at your dental state board rules. So while you've got the syringe in your hand, label it. And you'll see here, This is, I took a Sharpie and I labeled Robenal, which is glycopyrrolate, which is an anticholinergic. I put the concentration is 0.2 milligrams per milliliter. The date I drew it up is 11/13, and I did it at 7:40 in the morning. We use a 24-hour clock. And then my initials, even though it looks bad, are AJS that's there. And you're going to want to put it alongside the numbers on the syringe so that you can see all the hash marks on the syringe. We have in the operating room printers that absolutely label the drug, and so that we can put it on. I just wanted you to see what the label looked like for the succinylcholine, who drew it up, it's got my initials on it, and how you can see the milliliter and the hash markings on the syringe with the label in plain sight. That is just a great way and a great habit to do that. There are some people that will wrap it around the bottom of the syringe, right where you put your fingers, the finger rest on the syringe, and I just don't like doing that. As we talked about earlier, whenever you're drawing something through the gasket on the vial, wipe the top, and before you inject it, another standard of care is to scrub the hub, even if it's a plastic or a rubber hub or one of these lure lock hubs. Make sure you scrub it before you attach the syringe to it and give the patient the medication. And also make sure that you read the bottle for each of the different types of meds there are. I'm going to show you some look-alike vials that are totally alike or very, very close, and they're two totally different drugs. So the furosemide or Lasix on the left, it's got the same color top as the midazolam or Versed vial on the right. Just make sure you read it while you've drawn the drug up, label it the way that we just showed you. Here's famotidine, which is Pepcid on the left, same color, but a different size or shaped vial on the right, which is Bridion, which is Sugamidex, that we use to reverse non-depolarizing muscle relaxants like Vecuronium or Rocuronium, something that you wouldn't use unless you're working in the OR. But just to show you two totally different drugs. If you're looking at this picture, they were doing some work on Niagara Falls back in the late 60s. This was 1969. So they shut off the flow to Niagara Falls, and that's what Niagara Falls looks like without any water going over it. Let's look at the 13 most common dental office emergencies. There's a general emergency response that I just want to go through with you. Just kind of the basics of what we do for any emergency. We're going to talk about hypotension and hypertension, laryngospasm, and we've got a new treatment for that I didn't even learn in school, but it's something that we do now for the laryngospasm emergency, and we're going to go through that. We're going to talk about acute airway obstruction, cardiopulmonary arrest, allergic reaction to drugs, angina pectoris, possible myocardial infarction, also called an MI. We're going to talk about emesis and possible aspiration of vomit, convulsions and seizures, oversedation, hypoglycemia, drop in blood sugar, asthma bronchospasm, and respiratory depression. Before we go into those, I want to go through something with you and why you're training yourself and your staff to be able to help take care of your patients in the office. Your most valuable asset, of course, your patients and your staff to help you take care of your office and do things hopefully in a professional and correct way. So instead of getting fixed on one thing, like what we see here with the EKG, is they've all of a sudden been in what looks like a sinus rhythm, a normal sinus rhythm, and suddenly go flatline. Instead of panicking, freaking out, and fixing on that flatline, there's probably more than likely a patch that came off or one of the cables came loose from the patch. So probably the most simple thing, I think that they call that Occam's razor, is likely going to be the explanation for that. So rule out the worst case scenario. It is rarely that. Don't forget that you've got redundant monitors like your pleth or your SpO2 or your SAT scale. So if you see them go flatline and you see their pleth going along with a continued rhythm, then you know that they haven't gone flatline. Because if they're flatline, the pleth is going to go flatline also. So don't get fixed on the one thing. Go with the easiest possible solution. Everyone must accept that the first assumption may be wrong. And this is where their training and your training come in, so that you're able to then go to at least one thing and maybe know that there's another thing that you could go to. And your staff can help you with that. I can tell you that having witnessed a cardiac arrest with a trained team that sees cardiac arrest in the cardiac cath lab, the catheter lab, where they're doing cardiac caths, and a patient codes, that even though these people see it a lot, it is absolute stress and panic while the patient is coding. And these are people that are good, well-trained, and still it's extremely stressful for them. So if somebody's short of breath, try to figure out what is going on. Do they need some oxygen? Are they anxious? And then we can move on to things like asthma and such. If indeed you see something, an artifact on a monitor, you can believe the monitor but question it. And a lot of times it's the last explanation for a problem. So if we're looking at the EKG and we see rhythms, we progress down to first degree AV block, second degree block, and third degree block. You've got to believe that those are not artifacts for that patient. And when I say that I want you to tune the patient up and have them ready to rock, I expect that you're going to have any physician consultations, what meds they're going to be taking, what time they're supposed to come in. You know, you want early appointments for your diabetic patients so they can get back on their blood sugar to regulate, make sure that it's level. You want to get back on their eating regimen, especially if they've taken oral hypoglycemics, Ozempic, something on this order, or if they're getting an insulin dose. We want to get them to have a level blood sugar. So make sure the patient is tuned up at the right time, ready to rock, so that you don't see things like these bad heart rhythms that we're seeing in these strips. So don't bias the team with a previous conclusion. You're the doctor, but what you may be looking at and seeing may be biasing them, and they need to have the chance to say, you know, this looks like such and such. And you've got to create an environment so that they're able to talk to you in that way and not be having any reprimand or put down. We need team respect. So the team is ready to rock. Everybody's smiling. We got everything. We're happy. So again, all of the dental emergencies and the protocols from the algorithms that are in your notes that you'll be able to print and put with your emergency drug kit are again based on the CABDs: circulation, airway, breathing, defibrillation, and it's early. You've got to get on circulation. It used to be ABCDs where we were worried more about the airway and the breathing, but now if the patient has no heartbeat, they're not pumping blood, and the tissue is dying, we have got to get pumped blood that's full of oxygen to that patient. So let's talk about the general emergency response protocol. So use this protocol. This is going to be your backbone for the other types of the 13 emergencies that we're going to be talking about. The office does not have to call 911 for every emergency. There are some emergencies, like a patient fainting, or somebody with a low blood glucose, or somebody that may be choking or have low blood sugar, something on this order that you should be able to treat. And your office should have a basic way to respond to any emergencies. So with the generic anesthesia emergency response protocol, we're going to quietly alert the immediate staff. The whole office does not have to go into chaos, so there's no need to alarm other patients in the office. Make sure the patient is positioned safely. Follow your CABDs. Make sure we've got circulation, we've got a good SAT, we've got a good blood pressure, and that the patient isn't in any kind of a lethal rhythm. One of the first drugs you're going to treat the patient with for all these emergencies is going to be oxygen. And you'll want to bring the oxygen tank and the bag valve mask. And you don't call 911 for every emergency. So if you see a test question, let's say, that's got all of the above, look for that 911 emergency, because you should be able to handle some of these emergencies. And everybody, the doctor included, needs to be ready to listen to orders and carry out orders. So the goals for what you're doing with the general emergency spot are, again, to quickly alert the office, assist the patient in maintaining their CABDs, assist the dentist and whoever's treating the patient to help that patient. Everybody should be able to assist each other, and you don't have to call 911 for every emergency. Let's talk about our next dental office medical emergency, and that is hypotension. Hypotension is also called syncope if it's in an awake patient and they, if you will, faint. So this is going to be, again, your most common anesthesia medical emergency. We saw that with the guard that collapsed in the picture at the beginning of the lecture. So we have a transient decrease in cerebral blood flow, and we're not going to be bringing enough glucose to the brain. Some of the causes of that transient decrease in cerebral blood flow are hypoglycemia. Don't forget that if we're doing sedation for a patient, that they're going to have low blood sugar to begin with because they haven't eaten anything. This is why we want our patients that are diabetic to be our first patients of the morning. They're going to have possibly an intravascular fluid deficit because, again, they've been NPO. If they're following the rules the way that we do with the fasting guidelines, if they've been NPO, no clear liquids for at least the last 2 hours, so the patient's going to be dry, and in some cases the patient's going to be real dry. And then there could be certain medications that the patient is taking, like their blood pressure medication, but it's going to really lower their blood pressure. Certain patients will have emotional distress. They smell the dental office, the zinc oxide, the eugenol, the cleaning solutions, whatever it is, the sounds of the high speed. Maybe there's a patient over in another operatory, or that they can hear from out in the reception area. Just the sights and the fear for not only their monetary, but their pain and severe pain and such. It's just not a trip to the park for sure. And one of the most common causes for hypotension is the vasovagal response. So being at the dentist, fear of needles, fear of pain again, they can have a real quick drop in their blood pressure, especially to their brain, or a low drop in blood sugar. So with the vasovagal response, we see that vagus nerve there, and we see vaso meaning vasculature. The thoughts of being at the dentist and all those things can be triggers, but you'll see things in the patient that you can plan for. If you're astute and your staff is astute, you can really quickly start taking care of this before this turns into something bad. It could be a cold sweat. They might develop nausea and potentially vomit. They may have, because of that drop in blood pressure, especially to the brain, slurring of speech, vertigo, dizziness, they could be falling, and they may say, I am feeling really bad before they go down. I have had this happen before in the dental office, and it doesn't have to be the little old lady or the teenager or whatever. I've seen big men go down with this sort of thing with the vasovagal response. So again, which cranial nerve is the vagus nerve? We've mentioned the vagus, and there's that word vasovagal. It's going to be cranial nerve number 10 if you see the old mnemonic to be able to remember the cranial nerves. So the way that we're going to treat hypotension is we're going to get the patient into Trendelenburg. So we want to get blood flowing to the brain. Elevate their legs, and that's going to be giving them almost a transfusion of blood from the central circulation in their legs up toward their brain, more toward the center of their body or the higher portions of their body, especially if they're in Trendelenburg, which is going to be the head down position. Turn off nitrous, turn up oxygen. We're going to want to open fluids if you've got an IV going and have another bag ready to go so we can fill that NPO basal space that needs to be filled up because they've been NPO and they're dry. In Missouri, we're required to have an ammonia capsule. So I've got that ready in my drug kit, and you're going to need to check your drug toolbox from your state board to see what it is that you need to have in your office. And in your drug kit, you're going to have ephedrine, and that's diluted. It's 50 milligrams. And we take that bottle and we dilute it with 9 milliliters of IV fluid, and that will give us 5 milligrams per milliliter of ephedrine. Or we're going to want to double dilute phenylephrine. It comes too potent in the bottle, and it's got to be not single diluted like ephedrine, but double diluted so that we come out with 100 micrograms per milliliter. And there's some recipes that you're going to see at the end of this lecture that you'll have also to be able to use that. And then we're going to want to get cold washcloths to the patient's head and cool off the room. They're going to really have that dry sweat. I can tell you that I experienced a vasovagal response in the operating room when I had a patient that was in her 80s that was having a surgical procedure for a fracture in one of her discs. And they were going to do what's called a kyphoplasty, where they inject plastic in to seal that crack, if you will, in the vertebra. So as I looked up, the patient's prone, the surgeon's getting ready to wash his hands and get scrubbed. In other words, get some gown on, get sterile gloves on. And I looked up at the monitor and I saw what looked like the patient was in VTAC. I remember sensing the vasovagal response. I had a cold sweat and my eyes open real wide, and I could see that the surgeon was tapping the leg of the patient, and it created an artifact in the EKG. And I was pretty upset with the surgeon, but it was somebody that I knew, and fortunately the patient was not in VTAC. Anyway, so this is the way we help someone that's fainted. Legs up in the air. It's an auto transfusion of blood, head down into Trendelenburg. If we turn the patient up in the air so that their legs were lower than their head, that's called reverse Trendelenburg. But I want you to see that Trendelenburg is the head down position. So the ammonia capsule is pretty old-fashioned, but we're required to have it in Missouri, and I'm sure there's other states that require that. So follow your rules. Go to your dental board. And here's what the drugs, ephedrine and phenylephrine and the ammonia capsule look like. All the ammonia capsule is a glass ampule that's wrapped in cloth and then surrounded by paper. You crack it and you've got ammonia vapors that come out that are, quote, supposed to make the person wake up. So increase their blood pressure. But we're going to want to treat that patient with an IV with ephedrine or phenylephrine, depending on what their heart rate and their blood pressure are doing. And this is training that you should have had in your sedation courses. And here is the goals of the procedures. We don't want the patient to injure themselves if they're falling. We're going to help them regain their consciousness. We're going to get their blood pressure up to a homeostatic level where they live to get blood flow to their brain. So we're going to want to maintain that blood flow to the brain and make sure the patient is breathing. We may have to give them supplemental oxygen. Let's talk now about hypertension. So just a review of what hypertension is. I will never ask any questions on a test, and I don't expect you to memorize it except to know what normal blood pressure is in a normal, healthy adult human. Naturally, they're going to be an elevated blood pressure because they're coming into the dental office. But if they've got a sustained blood pressure, even while they're sedate or relaxed, then we've got problems and they need to have a physician referral, or you have to abort the procedure if they have high blood pressure. Stage 1 and stage 2, you can see the numbers, just know what normal is. And then if there's a hypertensive crisis, and I've seen this before with relaxed patients, I won't even do or even consider working on the patient that day and insist that they go to the emergency room immediately. In order to understand hypertension, we need to discuss the basics of the autonomic nervous system. Remember, that's the automatic, something that we really can't control. I know that there's studies that said that it is possible, but just know that that's the automatic system. And it's broken down into two subunits, if you will, the parasympathetic and the sympathetic system. The neurotransmitter for the parasympathetic nervous system of the autonomic nervous system is acetylcholine, and the neurotransmitter for the sympathetic side is norepinephrine. And these two systems counterbalance each other. So if one predominates, then certain vital signs are going to predominate. And if the other is taken out of the scene, if you will, by medications and such, the other side will dominate in that way. So they're totally in touch with each other in a normal, healthy patient. And again, they counterbalance each other. The picture that you see of the parasympathetic nervous system shows you the anatomy of the system. You can see that the vagus nerve, nerve 10, is innervating a lot of organs. We have parasympathetic nervous system that goes to the eye, it goes to the pupil, it goes to our salivary glands, our parotid gland, and then notice that it goes to the major organ, the heart, stomach, the pylorus, where the duodenum takes over, and after the stomach empties into the duodenum, the colon, the bladder, and even in the sacrum. Notice how nerve 10, that cranial nerve 10, all the organs that it innervates. It's interesting that the word vagus is from the Latin word for vagor, which is meaning to wander, stray, roam, rove, go about, ramble, and such, because it really does ramble through a lot of organs. And I can tell you that when a surgeon is touching or an endoscope is going through the colon or such, we're going to get vagal stimulation, and the heart really will slow down. It will become bradycardic for sure whenever that is stimulated. This is a close-up view of the nerve that goes to the terminal of the surrounding nerve. So we've got the neuromuscular junction, or the space between nerves, the axons. So granules of acetylcholine are released. They go to receptors on the postsynaptic side of the nerve and cause a stimulus there. And then those same granules are extremely rapidly reuptaken, if you will, into the presynaptic nerve. Let's look at the sympathetic nervous system. You can see that there's a chain of sympathetic ganglia alongside the spinal cord, and that they are going to the same organs that the parasympathetic nervous system went to, but it's a totally different anatomy. Remember, it's going to act in the complete opposite way of the sympathetic nervous system. Notice it's going to the colon, the kidneys, the bladder, the pylorus, the heart, the bronchi and such, the eye. So with the parasympathetic nervous system, that's going to be the relax, slow down, digest, salivate portion of the autonomic nervous system, where the sympathetic nervous system is going to be the fight or flight. We're going to really increase blood pressure, heart rate, and such. Complete opposite effects of the parasympathetic side. And you can see the axon that is going to be releasing granules of norepinephrine to stimulate the receptors in the postsynaptic nerve cleft that's there. And again, that neurotransmitter is norepinephrine, where with the parasympathetic side, we've got acetylcholine. And there are the two nervous systems side by side to show you how different they are anatomically, but that they're going to the same organs. I want you to see this diagram of the arterial and the venule. You're going to see that the arterial is the very end of the line before capillaries branch, and that we have fluids and minerals and hormones that are going from the cell to the cell and such. The big thing to memorize here, and I want you to take a snapshot of this picture, is the arterial. It's going to be very, very important in hypertension and relieving hypertension because, if you will, the arterial is the noose. So if we tighten the noose, which is going to be the musculature of the arterial, this is where blood pressure is determined. So if we tighten that, blood pressure is going to go up. And we've got meds that we can give a patient artificially to get blood pressure up. So it's going to tighten the noose. There's three main types. There's more types of adrenergic receptors. You see the word adrenaline there, which is going to be the sympathetic side of the autonomic system. Receptors that I want you to see are going to be alpha 1, beta 1, and beta 2 on the sympathetic side of the autonomic nervous system. If alpha 1 is stimulated, if you look at that Greek letter alpha, it looks like it's almost a noose. So if I were to tighten and stimulate alpha 1, it's going to cause vasoconstriction of the arterioles and of arteries, but especially the arterioles, because physiologically that is where blood pressure is determined. Beta 1 stimulation is going to increase heart rate. Beta 2 stimulation, where we're concerned, causes bronchodilation. So it's going to relax the bronchi to open them up in case we're having a respiratory emergency or something is stimulating the bronchi to constrict. So this is a summary of the adrenergic receptors that I want you to notice and I want you to learn. So we seek out the cause of the hypertension because each one of the different types of hypertension are treated with different meds. And here are the steps. We're going to have to think about what the patient's hypertension is caused by. Is it pain? Is it anxiety? Did they, God forbid, have a stroke in the chair? Are they having heart failure? Are they having an MI? Did they not take their hypertensive medications, the antihypertensive medications? So we're going to want to go ahead. If we don't have an IV, we're going to want to get one going. It depends on the severity of what is causing the hypertension. A lot of these we can treat in the office, but if it's from an MI or someone having a stroke, this is a call 911 emergency. So you have to make a diagnosis of what is causing the hypertension. If they're having pain, should we just go ahead and freshen the local anesthetic? Obviously, yes. We might want to add a narcotic, a potent narcotic intravenous analgesic like fentanyl if we're using Dilaudid or morphine or Demerol IV. We're going to want to go ahead and take care of that pain. And we also have non-narcotic analgesics, pain medications such as ketorolac, Caldolor, which is going to be IV ibuprofen. Ketorolac is Toradol, or IV acetaminophen. We might want to give the patient, if it's beta 1 stimulation, a beta blocker. We're going to want to make sure that they don't have any asthma before we give one of the Olols or the Lol beta blockers such as Esmolol, Labetalol, or Metoprolol. And we have one pure antihypertensive, a drug that I really like to use, but it's only in certain situations after I've made the diagnosis for the patient, and that is hydralazine. So we're going to want to make sure we've got a firm diagnosis of what is causing the hypertension. You've got your LOL drugs, the beta blockers that are going to block both beta 1 and beta 2 receptors. Remember, beta 2 is going to be in the lungs, so we're not going to want to block those for somebody that's having respiratory issues, especially asthma, because it's going to block both beta 1 and beta 2. Hydralazine in this picture loosens the noose. So it's going to drop blood pressure. And with any of these drugs, we're going to want to go and titrate the drugs. We're not going to want to slam them into the patient. So with hydralazine, you're going to want to single dilute that in a syringe so that it comes out to 5 milligrams per milliliter. I would start with 5, and if it's a severe hypertension, maybe 7.5 milligrams IV. But start low. You can always add to it with any of the drugs we've talked about in any of the parts of the courses that we're talking about drugs. Again, titrate. Let's talk about laryngospasm. It's defined as an extreme, uncontrolled spasm of the powerful muscles surrounding the small opening of the airway or leading into the trachea. So we can see in these pictures, there are some powerful muscles there. Get oriented as to where the tongue is, the hard palate, the soft palate, the trachea, the esophagus and such, because those are narrow, sharp, rounded airways. There's not a gradual curve there, and those can get blocked very quickly if liquid or something solid like vomit or water or a blood clot or a dental instrument goes in and causes spasm. So again, the vocal cords in this picture show you the powerful muscles that immediately spasm to protect the airway and to block the airway. So we've got to be able to block that so that we can, after we suction or get the offending agent out very, very quickly, we're going to want to be able to treat that very, very quickly. If you look at the picture of the adult vocal cords, you can see they're not real big, but they're larger when compared to the pediatric airway. If you look, the pediatric patient is being exposed of their vocal cords with a laryngoscope blade. And you can see that that little tiny black dot is the opening to their airway. So if we have water or liquid or whatever go down the wrong pipe, instead of going down into that esophagus, unfortunately, that water can go down into the trachea, and our bodies are exquisitely set to be able to prevent anything foreign at all from going into the trachea. So that water or that liquid, that blood can go down into the trachea. And if we're giving sedation to the patient, like fentanyl along with Versed, could be propofol, could be one of the other drugs you're using, lorazepam, whatever for the patient, we're going to blunt the reflexes even more. So it's going to make it that much more, if you will, dangerous for the patient to be able to clear secretions, blood, any debris, any foreign objects that go down toward the vocal cords and into the airway. So to treat laryngospasm, we're going to want to get the patient flat in the chair and adjust the chair, if you're standing, to a height so that you can get to the patient. We're going to immediately apply something called Larson's maneuver. This is a newer technique that we have to treat the patient very quickly for laryngospasm. I would get the oxygen, have somebody go and get that, crank it up to full blast. You can have the bag mask valve ready to go. Let's see how Larson's maneuver works though. Have a Yankauer or a tonsil suction ready, and dental boards require you to have succinylcholine available if you're doing IV sedation for a patient. I'm not thrilled at all with you having to use that drug. It requires a lot of training to be able to use succinylcholine, and your state dental board may require that. So Larson's maneuver, you can see in this picture, you're going to be applying intense, if you will, pressure with your digit into the area that is the ascending ramus, the space between that and the ear. You're going to push in hard. It's very stimulating, and it's going to stimulate not only the patient for feeling pain, but it's going to stimulate the musculature around the aperture to the vocal cords. So again, it's behind the angle of the mandible. I'm going to show you views. This is Tina. So this is her left side, straight on, and then the same thing then for her right side. When you're looking at this picture of the fellow with the taped eyes, you'll be able to have a movie there to see how to apply. And you can see the redness underneath the patient's ear. You can see where the person applied Larson's maneuver. When I was trained, we did the bag valve mask and the oxygen tank. So this is going to be your second line of treatment. Larson's maneuver should pretty much clear it once you've gotten the offending agents out of the mouth. So with that, we're going to want to get the patient down flat in the chair. We're going to want to apply the C and the E around the patient. So here is the C, and here's my fingers for the E. The C is around the mask, and the E are my fingers on the mandible, pulling the patient's face into the mask. And then we're just going to hold positive pressure with the bag valve mask or the Yambu bag. So we've got to have a good fit so it doesn't leak, and that will break the spasm. And then we're going to want to have a tonsil suction or a Yankauer. This is one that is a reusable one that goes into the high-speed suction. So you should be able to buy those from your dental supplier, reusable Yankauer suction. I'm not thrilled again with succinylcholine, but your dental board may require you to have succinylcholine, which has to be kept refrigerated and nearby the patient. Something that works really, really well if you're wanting to apply something IV is the IV lidocaine. We saw this earlier when we were talking about multiple doses, but if you draw up 5 milliliters of 2% lidocaine and bolus it into the IV and then open up the IV, it's going to relax the paralysis or the spasm of the musculature around the airway, and it works really, really well. Something new that's on the way that is being used to treat in lieu of succinylcholine is our non-depolarizing muscle relaxant, rocuronium, and its reversal agent called Sugamidex or Bridion. Both very expensive drugs, and something where a dental society would have to have this, where you all would get together and pitch in on the cost of that. and make sure that it's updated and not expired. So if you do paralyze the patient, you're going to have to breathe for them, and you're going to have to monitor to make sure that they're back from their paralysis. So I'm not a fan of you using succinylcholine or rocuronium. Notice that with the parasympathetic nervous system, that we talked about the neurotransmitter for that side of the autonomic system as acetylcholine. And succinylcholine is the molecule acetylcholine back to back. So it will cause a brief paralysis of the musculature around the face and around the vocal cords and the musculature around the airway. Let's talk about acute airway obstruction. The biggest obstructor is going to be the tongue, and especially a sedated tongue is going to be very relaxed and is going to be blocking the airway. It becomes like a side of beef if the patient is really, really relaxed. That tongue is going to be your main blocker, and you're going to look and see that the diaphragm's contracting, they're not moving air out. The diaphragm's contracting, they're not moving air out, and the patient will form a rocking horse as they're trying to breathe and exchange air. So the patient cannot inhale and exhale at all through their nose or their mouth. And a lot of the causes that applying toward dentistry are going to be foreign objects, and there's going to be plenty. So you've got to guard the airway. Things like crowns, filling materials, teeth, broken teeth, roots, endodontic instruments, dental instruments, the rubber dam clamp, cotton rolls, and 2x2s, as well as blood, saliva, vomit, or nasal or sinus secretions. So we've got to really guard their airway. One of the things that I hate the most about working, if you will, with dentists, and I am a dentist and a nurse anesthetist, is the fact that I am sharing my airway as an anesthesia provider with you, the dentist. So we've got to respect each other and take care of the patient, and you've got to really guard that airway. If air is barely squeaking by, that is probably due to laryngospasm or some amount of blockage due to airway obstruction from the tongue usually. So in order to treat this, we're going to want to get the patient flat in the chair. We're going to want to get the oxygen, hook up the bag valve mask. If there's something in the airway, we're going to have to go down and look. You may have to use a laryngoscope to look at that. If you still can't break the spasm, you have an emergency cricothyrotomy kit in your emergency drug kit and your emergency cart. So we're going to want to go ahead and take care of the patient. You're going to want to use a McGill's forceps to get the foreign object out of the airway, and be ready to have the IV fluids open so that you can give meds to the patient if need be, and have another bag ready to go. So you've got to very quickly establish the airway. If it's with an artificial airway, it could be a bag valve mask, it could be an LMA that you see in the top right of the photo, or an endotracheal tube, or an emergency cricothyrotomy. This is urgent. We have got to get the airway open, and we've got to get oxygen to the patient, especially to their brain. So remember your CABDs. There's a laryngoscope and a styletted, it looks like a coat hanger in the endotracheal tube. There's the Yankauer suction again. These are different types of McGill's forceps. So you have these in your emergency kit. If you don't, you should, and know how to use them. On the left, we have far left an adult McGill's, and next to it is a pediatric McGill's. And then years ago, there was a McGill that has a totally different shape that's available now. So we're going to want to just open that airway. I just want to show you pictures of video laryngoscopes. It looks like, for people in the field, that the video laryngoscopes, since they've come way down in price. You can see that this picture is a CMAC, and there's also a glide scope, and there's a lot of different. Here's a McGrath that we're using to intubate the patient. You don't have to bend over. You don't have to look down the airway. You just slide into the vallecula, which is going to be the space between the base of the tongue and the epiglottis, and lift. And you can see the endotracheal tube or the foreign object so that you can get the McGills down there and expose and look at so that this patient can then breathe again. Here's a glide scope showing you the same thing. They're wonderful when we're intubating patients. Hopefully there's not going to be any foreign objects that's going to block the airway. Just to show you the anatomy of an emergency cricothyroidotomy, you're going through the cricothyroid membrane. Remember, thyroid membrane, or the thyroid cartilage, is going to be the Adam's apple, and the cervical disc just below it is going to be the cricoid cartilage. And so that membrane in between, there's not a lot of vasculature there, and there's no thyroid gland there, fortunately for us, so that we're not perforating those. And in case of an emergency, you should have your cricothyrotomy kit. And you can see that this is probably a 12-gauge needle that's going to puncture that site so that we can then hook up to the tracheal kit, the cricothyrotomy cannula, hook up a tube to that and breathe the patient to get their oxygen up with our bag valve mask. Lastly, let's talk about cardiopulmonary arrest. This is where your training for ACLS comes in, and this is especially where we see the CABDs. Remember to start pumping on the chest immediately. Use proper technique to be able to compress the chest. Remember, 1.5 inches. Make sure that you're following the correct rate and make sure that you're looking at the rhythm of the patient. Get the crash cart, O2, get the AED out, position the pads where they're supposed to be, call 911. And fortunately, ACLS has been made easier for us. We had a lot of things that we had to know in the early days of ACLS, and we had to know them cold. And especially, as I said, in an emergent situation, it's really hard to remember things. It is Panicsville. So the drug that we have to remember now is an ampule of epinephrine. And don't forget that you're going to have a bunch of unexpired epinephrines there to be able to get the patient's heart into a beating rhythm again. And make sure you grab even a paper towel, somebody grab an anesthesia form, and write down when you gave these meds. And you know you give epinephrine every 5 minutes, and that we constantly are pumping the chest of the patient with the C of the CABDs, so the circulation, and that we want to get that defibrillator there in case there's a lethal rhythm that has to be defibrillated. And it's okay to go to your ACLS protocol cards. If you don't have them, buy them. And the fortunate thing is the new ACLS protocols, the ones that we've used even today, I'm recording this in September of 2023, those were created in 2015, and they really have not changed that much. And they used to change all the time, but fortunately they have not changed at all. So some facts, and I know that these are old facts, is that it's extremely rare for a patient to go into cardiopulmonary arrest in the dental office. This is 2001, and it was 0.002% of patients. So it's extremely rare. And that patients, this is going to be the number one cause of death from cardiovascular disease. So the statistics change, but just know that this is going to be the leading cause of death. And don't forget, as I said before, you're not going to have these patients typically in your office because you're not going to allow them to be there. They're going to be tuned up, and ready to rock before they're even in your office. And if you have any questions or worry about them, then you just don't treat those patients in your office. Avoid this. And cardiovascular disease is going to be the number one cause of death in women. The latest statistics, and I know that they change, are 2,200 Americans die each day in the United States, and that one person dies every 39 seconds. And that each minute that the person is in the lethal rhythm, ventricular fibrillation, if you're not shocking them, their survival decreases 7 to 10%. So that is why the C and then the A and the B and the D have to be done very, very quickly. And despite 911, 6% of patients survive without some kind of neurological impairment, even though you've gotten the heart started again. And I know that they used to teach us, as I said years ago, that probably you're going to resuscitate the patient, but it turns out that probably you're not going to resuscitate the patient. So be prepared for that. Make sure you guys talk about it after the scene. Just know that hopefully you didn't treat the patient that wasn't tuned up and ready to rock. And unfortunately, you have to write a form that goes to the dental board, usually within 5 days of an event happening in your office. Check your dental board rules. And unfortunately, you're probably going to get some kind of cite or reprimand from your dental board, even though you did the right thing to be able to treat them. They probably should not have been in your office in the first place. I'm trying to be honest with you in what I'm saying here. So start CPR, start to pump the chest, get the bagged mask valve, get the defibrillator in place, and shock the patient ASAP as soon as possible. So early defibrillation, and you can see the pictures on the pads showing you where they go on the patient. And the only drug you have to know it's not diluted is 1 to 1,000 epinephrine. So 1 ampule, it's equal to 1 milligram. It's not to jumpstart the heart, it's to hopefully get back a sinus rhythm. The defibrillator does not jumpstart the heart. It erases chaos. It erases a heart that is going through one of the lethal rhythms like VTAC or VFib, ventricular tachycardia, or ventricular fibrillation, where you've got a chaotic rhythm going on, if you will. It's not even really a true rhythm, but there is electrical activity there. So we're going to want to erase the chaos, and hopefully then sinus rhythm will take hold and take over the patient. So your dosages are 1 milligram every 3 to 5 minutes. Use your protocol cards because it's stressful and chaotic for you and the team, and make sure you document. It doesn't have to be pretty documentation, but you're going to want to go ahead and write down when you started not only defibrillation, but when chest compression started, when defibrillation occurred, when you gave your first dose of epinephrine, when 911 arrived, these sorts of things. So again, the rhythms and the algorithms haven't changed. I said 2015, but it's 2016. And those protocols are so good that they really haven't changed much in that time. If you don't know how to start an IV, it's going to be really, really helpful. And hopefully you've got an IV started. You might have an emergency kit, and training can be received for that. We also have another device if a person comes into the emergency room, and especially if it's a pediatric patient with little tiny veins, but it can even be, say, an obese patient or a patient that is just in really bad cardiovascular status. We've got an intraosseous or an IO that we can start on the patient to insert just below the medullary portion of the long bone, like the tibia, and we give the same dose of the drug. We're going to talk about that later in some of our other lectures that you'll see through your course. Thank you for attending the course. You can see our references, and we'll see you on the other part of dental office medical emergencies.